Hello everyone, welcome to today's reading session. Yesterday we took off day. Yesterday we didn't read a session. I had few of my personal reasons yesterday, so didn't able to stream. I'm here today. I don't remember what we read last. Okay, yes, we read thrombogenesis. Let's start from coagulation and kinin pathway. PT monitors extrinsic and common pathway. Reflect. Prothrombin monitors eccentric and common pathway, reflecting activity of factors 1, 2, 5, 7, 10. PTT monitors intrinsic and common pathway, reflecting activity of all factors except 7 and 8. Okay. Collagen basement membrane activated platelets. Contact activation intrinsic pathway 7 to 7A and 11 to 11A. Okay. C1 both 12A. Not, I was reading it as 7, right? So that was wrong. 12A and 11A. Inhibited by C1 esterase inhibitor. That in turn inhibited by kallikrein. HMWK leads to bradykinin. Kinin cascade. Increase vasodilation, increase permeability, increase pain. Okay. Factor 9A to 11A. 8A to 8 with von factors. Regulatory anticoagulant proteins, protein C and S. Anticoagulants, heparin, low molecular weight heparin, direct thrombin inhibitors, that is ergaproban, bivalirudin, and dabigatran. Okay. Also, prothrombin converts to thrombin 2 to 2A. So, fibrinogen converts to fibrin monomer 1 to 1A, common pathway. 8A. 8 to 8A, fibrin stabilizing factors. Fibrin may stabilizes platelet plug. Fibrin degradation products, that is D-dimer. Plasminogen to plasmin, TPA, thrombolytics, altiplase, retiplase, tenecteplase, antifibrinolytics, aminocaproic acid, tranexamic acid, fibrinolytic system. Okay. Tissue factor extrinsic pathway. Okay. Anticoagulants, low molecular weight heparin, that is dalteparin, enoxaparin. Okay, heparin Direct TNA inhibitors, that is Abaxaban, Fondaparinux. Okay. In hemophilia A, deficiency of factor 8 XR. Hemophilia B, deficiency of factor 9 XR. Hemophilia C, deficiency of factor 11 AR. Okay, note kallikrein activates bradykinin, is inactivates bradykinin. Ester C1 esterase inhibitor deficiency leads to hereditary angioedema. Star requires calcium and phospholipid. Next, vitamin K dependent factors and cofactors. That is purple and green. Activates but not part of coagulation cascade. Low molecular weight heparin. High molecular weight heparin. High molecular weight kininogen. Vitamin K dependent coagulation, procoagulation. Vitamin K deficiency leads to decreased synthesis of factors 2, 8, 2, 7, 9, 10. Protein C, protein S. Warfarin inhibits vitamin K epoxide reductase. Vitamin K administration can potentially reverse inhibitory effect of warfarin on clotting factor synthesis. Delayed FFP or PCC administration reverse action of warfarin immediately and can be given with vitamin K in case of severe bleeding. Okay, neonates lack enteric bacteria which produces vitamin K. Early administration of vitamin K overcomes neonatal deficiency or coagulopathy. Suppression of gut flora by broad spectrum antibiotics can contribute to deficiency. Factor 7, shortest half-life. Factor 2, longest, too long half-life. Okay, liver. Okay, oxidized vitamin K inactive. Epoxide reductase warfarin liver failure. Reduced vitamin K active. Okay, inactive 2, 7, 9, 10 CNS. Gamma glutamyl carboxylase vitamin K dependent. Macho CS carboxylated 2, 7, 9 and 10. Anticoagulant clotting factors. Anticoagulation activated protein C requires protein S 9A to 10 to 10A. Direct factor 10A inhibitor. Okay, 5A leads to prothrombin. Second to a prothrombin inhibited by antithrombin 3. Also inhibited by heparin, low molecular weight heparin, direct thrombin inhibitors. Okay, again here purple vitamin K dependent factors. And green is equal to cofactor. Purple activates but not a part of coagulation cascade. Low molecular weight heparin. Okay. Let's new subtopic pathology section of hematology and oncology. RBC morphology. Type acanthocyte spur cells. Example they have given here. Diagrammatic representation. Associated pathology, liver disease, beta lipoproteinemia, vitamin E deficiency. Notes projection of varying size and irregular intervals Acanthocytes are asymmetric. Next, echinocytes, burr cells. Okay, liver disease, ESRD, pyruvate kinase deficiency. Not smaller and more uniform projection than acanthocytes. Echinocytes are even. Dacrocytes, teardrop cells, bone marrow infiltration, that is myelofibrosis. RBC shed a tear because it's mechanically squeezed out of its home in the bone marrow. Okay. Schistocytes, helmet cells, MAHA, that is DIC, TTP, HUS, HELLP syndrome. Mechanical hemolysis, that is heart wall prosthesis. Fragmented RBCs. Okay. Degmacytes, bite cells. G6PD deficiency due to removal of hens bodies by splenic macrophages. They dig them out of, bite them off of RBC. Elliptocytes, hereditary elliptocytosis caused by mutation in genes encoding RBC membrane proteins, that is spectrin. Okay. RBC morphology continued. Type spirocytes, example. Okay. Associated pathology, hereditary spirocytosis, autoimmune hemolytic anemia. Notes, small spherical cells without central pallor. Decreased surface area to volume ratio. Macroovelocytes, megaloblastic anemia, also hypersegmented PMNs. Target cells, HBC disease, asplenia, liver disease, thalassemia. Halt, said the hunter to his target. Increase surface area to volume ratio. Sickle disease, sickle cell anemia. Sickling occurs with low O2 conditions, that is high altitude acidosis, high HBS concentration, that is dehydration. RBC inclusions. Type, example, associated pathology. Notes, bone marrow, iron granules. Okay, sideroblastic anemias, that is lead poisoning, myelodysplastic syndrome, chronic alcohol overuse. Okay, perinuclear mitochondria with excess iron forming ring in ringed sideroblast. Require Prussian blue stain to be visualized. Okay, peripheral smear, oval jewelry bodies. Functional hyposplenia, that is sickle cell disease, asplenia, basophilic nuclear remnant, do not contain iron, usually removed by splenic macrophages. Okay. Basophilic stifling, sideroblastic anemia, thalassemia, basophilic ribosomal precipitates do not contain iron. Pappenheimer bodies, sideroblastic anemia. Basophilic granules contains iron. Pappenheimer bodies. Hin's bodies, G6PD deficiency, denatured and precipitate hemoglobin, contains iron. Phagocytic removal of Hin's bodies leads to bite cells. Requires supravital stain, that is crystal violet, to be visualized. Okay. Okay, next anemias. Anemias, okay, microcytic, normocytic, macrocytic. Microcytic mean corpuscular volume less than 80 femtoliters. Okay, hemoglobin affected, TAIL. Defective globin chain, thalassaemias. Defective heme synthesis, anemia of chronic disease, iron deficiency, lead poisoning. Anemias normocytic mean corpuscular volume 80 to 100 femtoliter. Non-hemolytic and hemolytic. Non-hemolytic, low reticulocyte index, iron deficiency, early anemias of chronic disease, aplastic anemia, chronic kidney disease, acute blood loss, hemorrhage. Hemolytic, high reticulocyte index. Okay. Intrinsic and extrinsic. Intrinsic membrane defects, hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, enzyme deficiency, G6PD deficiency, pyruvate kinase deficiency, hemoglobinopathies, sickle cell anemia, HBC disease. Extrinsic, autoimmune, microangiopathic, macroangiopathic infections. Okay. Macrocytic mean corpuscular volume more than 100 femtoliter. Megaloblastic, non-megaloblastic. Okay, megaloblastic, DNA affected. Defective DNA synthesis, folate deficiency, vitamin B12 deficiency, orotic aciduria, defective DNA repair, Fanconi anemia. Non-megaloblastic, diamond black fan anemia, liver disease, chronic alcoholic overuse. Okay, next, reticulocyte production index, also called corrected reticulocyte count, used to correct falsely elevated reticulocyte count in anemias, measures appropriate bone marrow response to anemic conditions, effective erythropoiesis, high RPI more than 3 indicates compensatory RBC production, low RPI less than 2 indicates inadequate response to correct anemia. Calculated as RPI is equal to percentage reticulocyte into actual HCT by normal HCT divided by maturation time. Okay. Interpretation of iron studies. Iron deficiency, chronic disease, hemochromatosis, pregnancy or OCP use. Okay. Serum iron in iron deficiency decreases, in chronic diseases decreases, hemochromatosis increases, OCP use. Doesn't matter, nothing changes. Transferring or TIBC. Iron deficiency increases, chronic disease decreases, hemochromatosis decreases, pregnancy or OCP use increases. Okay. Ferritin, iron deficiency decreases, chronic disease increases, hemochromatosis increases, pregnancy OCP use no change. Percentage transferrin saturation, serum iron, but TIBC, iron deficiency decreases, chronic disease decreases, hemochromatosis increases, pregnancy decreases. Increase versus decrease, primary disturbance. Transferrin, transport iron in blood. TIBC indirectly measures transferrin. Ferritin, primary iron storage protein of body. Evolutionary reasoning, pathogens use circulating iron to thrive. The body has adapted a system in which iron is stored within the cells of the body and prevents pathogens from acquiring circulating iron. Okay. Evolutionary reasoning, pathogens use circulating iron to thrive. The body has adapted a system in which iron is stored within the cells of the body to prevent pathogens from acquiring circulating iron. Okay. Microcytic hypochromic anemia, MCV, less than 8 of femtoliter. Iron deficiency, decreased iron due to chronic bleeding, that is GI loss, heavy menstrual bleeding, malnutrition, absorption disorders, GI surgery, that is gastrectomy, or increased demand, that is pregnancy, or leads to decreased final step in heme synthesis. Labs, decreased iron, increased TIBC, decreased ferritin, increased free erythrocyte protoporphyrin, increased RDW, decreased RI, microcytosis and hypochromasia, increased central pallor, shown in image A. Okay. Symptoms: fatigue, conjunctival pallor, restless leg syndrome, pica, persistent craving and compulsive eating of non-food substance, spoon nails, koilonychia. May manifest as glossitis, chillosis, Plummer-Vinson syndrome, triad of iron deficiency anemias, esophageal waves and dysphagia. Alpha thalassemia, alpha globin gene deletion on chromosome 16 leads to decreased alpha globin synthesis, may have cis deletion, deletion occurs on same chromosome, or trans deletion, deletion occurs on separate chromosomes. Normal is alpha alpha by alpha alpha, often increase RBC count in contrast to iron deficiency anemia. Increased prevalence in people of Asian and African descent. Target cells, see on peripheral smear. Okay. Of alpha globin gene deleted, disease, clinical outcome. First, alpha 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 beta beta. Alpha thalassemia minima, no anemia, silent carrier. Second, alpha thalassemia minor, mild microcytic hypochromic anemia, cis and trans. And hemoglobin H disease, HbH, excess beta globin forms beta 4, moderate to severe microcytic hypochromic anemia. Fourth, hemoglobin Barrett's disease, no alpha globin, excess gamma globin forms gamma 4. Hydroxypital is incompatible with life. Okay. Next is microcytic hypochromic anemias, continued. Beta thalassemia, point mutation in splice site or Kozak consensus sequence promoter on chromosome 11 leads to decreased beta globin synthesis, that is beta positive, or absent beta globin synthesis, that is beta 0. Increased prevalence in people of Mediterranean descent. Beta globin genes mutated, positive, disease, clinical outcome. First, beta thalassemia minor, clinical outcome, mild microcytic anemia. leads to increased HbA2. Okay, second, beta positive, or beta positive, beta 0, beta thalassemia intermedia, variable anemia ranging from mild or asymptomatic to severe or transfusion dependent. Second, beta thalassemia major, Cooley anemia, severe microcytic anemia with target cells and increase an isopoikilocytosis requiring blood transfusions, increased risk of secondary hemochromatosis, marrow expansion, crew cut on skull X-ray, skeletal deformities, extramedullary hematopoiesis, HSM, increased risk of parvovirus B19 induced aplastic crisis, increased HbF and HbA2 becomes asymptomatic after 6 months when HbF declines. HbF is protective. Chronic hemolysis leads to pigmented gallstones. Okay. For first, beta positive HBS or beta 0 HBS. Sickle cell beta thalassemia, mild to moderate sickle cell disease, depending on whether there is decreased beta positive HBS or absent beta. How to read this? Beta degree or HBS? I don't know. Beta globin synthesis. Okay, lead poisoning. Lead inhibits perochelate and ALA dehydratase, leads to decreased heme synthesis, increase RBC protoporphyrin. Also inhibits rRNA degradation, leads to RBC retain aggregates of rRNA, basophilic stippling. Symptoms: LLEEAAD poisoning, lead lines on gingiva, Burton lines, and on metaphysis of long bones, D on X-ray. Okay. Encephalopathy and erythrocyte basophilic stippling. Abdominal colic and sideroblastic anemia. Drops, wrist and foot drop. Treatment: chelation with succimer, EDTA, dimercaprol. Exposure risk increases in old houses built before 1978 with chip paint children and workplace adults. Sideroblastic anemia causes genetic, that is X-linked deficit in ALA synthase gene, acquired myelodysplastic syndrome, and reversible. Alcohol is most common. Also lead poisoning, vitamin B6 deficiency, copper deficiency, drugs, that is isoniazid, linezolid. Lab findings: increased iron, normal or decreased TIBC, increased ferritin, ringed sideroblast with iron laden, Persian blue stent mitochondria seen in bone marrow, peripheral blood smear, basophilic stippling of RBCs. Some acquired variant may be normocytic or macrocytic. Treatment: pyridoxine B6 cofactor of ALA synthase. Okay, A, B, C, and D. Okay. MCV more than 100 femtoliter. Description: findings: megaloblastic anemia, impaired DNA synthesis leads to maturation of nucleus of precursor cells in bone marrow, delayed relative to maturation of cytoplasm. Okay, this is going to be last Okay, actually we'll end it here and we'll check. Actually, the time is over. Macrocytic anemia will start tomorrow. We'll see what we covered today. Okay, we started from coagulation and kinin pathways, vitamin K dependent coagulation, procoagulation, anticoagulation. We read RBC, then we came to pathology section of hematology and oncology. We read RBC morphology, acanthocytes of spur cells, echinocytes, that is Burr cells, dacrocytes, that is teardrop cells, cystocytes, that is helmet cells, degmacytes, that is bite cells, elliptocytes. We read spirocytes, macroovalocytes, target cells, sickle cells, RBC inclusions, iron granules, Howell-Jolly bodies, basophilic stripling, Pappenheimer bodies, Hinz bodies. Then anemia, we saw the classification of anemia, reticulocyte production index, interpretation of iron studies, microcytic hypochromic anemia we have seen. The example, iron deficiency, alpha thalassemia, beta thalassemia, lead poisoning, sideroblastic anemia. Okay. Then macrocytic anemia will start tomorrow. So we are happy with our today's session. See you all in